I'm here. I ran. Okay, so hi, I'm Debra Metter. I'm from Seattle, Washington. Have a seat, you guys. Come on in. Get comfy. Great. All right, so how many of you are, we're going to do a post-op patient really quickly, and then we're going to go into a septic patient. How many of you guys work in trauma? Do trauma, immediate recess? Okay, good. This is exactly what we're going to be talking about this morning in a quick 20-minute spiel. How many of you do cardiac surgery? All right, so you guys, your boluses are like 250, 500? Yeah, I'm a trauma nurse, and so my boluses are about 2,000 sometimes. But what I want to talk to you about this morning, I'm Debra Metter. I'm from Seattle, Washington. I'm the trauma clinical nurse specialist up there. And what we want to talk to you about this morning is how we can use these tools, non-invasive cardiac output monitors, to help us make better decisions with our patients. When do they need fluid? And more importantly, when will they be responsive to fluid? So when I was training, the question always for me was, does your patient need fluid? Does your patient need fluid? Do you agree? So we give fluid, fluid, fluid. And then we came up with a technology that's actually been around since the 1920s, and it's called stroke volume variation or pulse pressure variation. Who uses that in their practice? Anybody? I'm looking for eye contact. No, yes, hello, good morning. Okay, perfect. You do a little bit? Okay, do you understand it? I mean, can you tell someone what it's about? That's okay. And that's totally fine. I had to study for 2 years. I'm really dense. It took me quite a while. So let's take a look at this patient, and we'll walk through this, how this is helpful for us to make fluid management decisions, optimizing fluid. So this is a post-op patient, had some sort of gastric dissection done. No medical history, with the exception of they are about 72 years old. They are on beta blockers, okay? And their normal blood pressure is 150 over about 110, okay? So they're hypertensive, that's their baseline. And the reason we've done this scenario is because it's really important, as you all know, is what is your patient's baseline? Sometimes we drive up blood pressures, vital signs to what we think is proper. So what do you guys think? Post-op patient, probably lost a fair amount of fluid. Looking at the blood pressure, is this patient okay or not okay? Not okay? I don't think they're okay. All right. Their heart rate clearly is not able to compensate for their low blood pressure. What about this index, 2.1? What's normal? 2 to 4? Agree? 2 to 4? Okay. So low. Low. Kind of concerning if they've lost a lot of fluid. What about this stroke volume? Normal 60 to 100, so high or low, low. So this concerns me also. We know cardiac output is stroke volume times heart rate. So if the stroke volume is low and this patient cannot compensate, are they in trouble? Absolutely. Our job, you guys, every single day with every single patient is asking the question, is my patient perfusing? That's it. And that's what I teach our nurses at where I work. I walk in the room and everyone's freaking out, and I just walk in and I go, is your patient perfusing? Is your patient perfusing? And if you guys look at me and they say, I don't know, I go, well, let's figure it out. Because that's really the question we're asking with all of our patients. Is oxygenated blood getting to the toes and back and everything in between? Do you agree with that? Okay. And we're not oversimplifying the complex work we do, but that is in the end what our goal is. What about this? This is SVR, systemic vascular resistance. It's 19 or 2,000. Normal's 800 to 1,200. What does that tell us? Are they vasodilated or are they clamped down? They're super clamped down. All right. So this heart has a lot to work against. Do you agree? Okay. So here we go. Stroke volume variation.
So this looks at this variation of the stroke volume as the blood moves through the pulmonary and the the pulmonary and the cardiac circulation. If you are positively ventilated, you have a closed chest, you have an arterial line, and you have a regular heartbeat, so those 1, 2, 3, 4 things, we can measure this. Can anyone tell me what that means? Stroke volume variation, or some people use pulse pressure variation. What does that mean? So when you have someone who's intubated and you're looking at their CVP waveform and it starts doing this, we call it respiratory variation, correct? That's what this is. It's looking at basically pulseless paradoxis of every time the heart beats, the variation of the heart as it gets positively ventilated. So your name is Michael? Michael, you're positively ventilated, and every time you take a breath, or the machine gives you a breath, you're pushing on your chest. That's going to squish the heart, correct? This is your heart, and it's nice and full. Do you think I can squish it very much? Probably not. So the waveform, or the variation, is going to be very low, so you're going to have a shallow waveform. If this is Michael's heart and it's empty, and I give him a positive breath, it's just going to go boom, correct? So you're going to have this big variation, a high number. We know, the world, knows through a lot of research that a stroke volume variation of around 10 to 13% is pretty good. They're pretty euvolemic, if you will. This does not answer the question, does my patient need fluid? This answers the question, will my patient respond to fluid? Very different, very, very different, okay? So looking at everything from here above, patient's not making urine, mental status is kind of wonky. Does your patient need something? And what are you going to do? You're going to give them, they're intubated, you're not making urine, the vital signs look wonky, way below baseline. What are you going to do? You're going to give them some fluid? You're going to give them a cup of water? No? All right. So let's say we give them a bolus. We'll go ahead and give them a bolus. We'll start with 500 cc's. And what we do is when we give them a bolus, we want to see if the stroke volume is going to go up, because that's what creates perfusion. And if your patient's going to respond to fluid, meaning it's going to increase your stroke volume, how much stroke volume needs to go up to say, yeah, I can keep giving Michael, or Miguel, sorry, doesn't matter? Yeah, because you just given up. You're like, this is how I spell my name, just call me whatever you want to call me. Okay, so we need to see a stroke volume variation, or stroke volume increase of over 10% to know your patient will give you fluid. Now, this is important to know, because if it's not, and you continue to give fluid, what's going to happen to your patient? They're going to get overloaded, and where does the fluid go? Right to the lungs. And is that okay? No. I tell you what, it breaks my heart when someone comes in with X, Y, and Z, and we end up giving them ARDS with delirium, and they're never the same, and their femur fracture is totally fine. Yeah, I mean, it's horrible. So this is really helpful. So we give a fluid challenge. We see if their stroke volume increases by 10%, okay? Stroke volume variation remains above 13%, so we're pretty confident that they will respond to fluid. And what we really want to know is where they are on this Frank-Starling curve. You guys remember that? Along with the Krebs cycle? We want to know if they're here. We want to know if we give them fluid, will their stroke volume go up? Okay, that's the Frank-Starling curve. We want to know if they're here, you guys. Stroke volume variation lets us know when they're here or they're here. CVP, blood pressure, heart rate, MAP, do not let us know the specifics of when the patient's responsive. So we give this patient fluid, and what happens? Boom! You got a 21% increase in stroke volume. And this is a real patient, you guys. Okay, so that we didn't, make this up just to make everybody happy. You see on the blue
Square there, 74. Stroke volume is now 74. Whoa, that makes us happy. Cardiac index has gone up to 2.7. This is good. The heart rate hasn't changed, but that makes sense because they're beta blocked, and heart rate times stroke volume equals cardiac output, which would probably be about, probably over a little about, almost about 5 here, okay, if we were in outputs. So are you guys happy? So here's our patient. Take a look at the numbers again. Do they still need something? Are they perfusing? What do you think, Leah? You want to give them more? Yeah, we can give them more because it's a computer. Let's do it, shall we? Okay. All right, let's give them more fluid and see what happens. Again, what we're looking for is if the stroke volume increases by 10%, we know definitively that patient can accept fluid. Our stroke volume variation is 16%, greater than 13. We're relatively confident they can receive fluid. And so we start our second challenge. These are basically the numbers from the last slide, but what's kind of cool with this technology is we can put this on event response. So I'm giving fluid now. Let's see what it does. Whoa, 10%, woohoo, okay? This is very cool. We see this going down to 12%. Why is it going down? Yes, because Miguel's heart is getting fuller of fluid, and it can only accept so much to create forward flow. All right, cool. The index has gone to 3. The stroke volume has gone to 88. How are you guys feeling? Feeling like we're saving a life? All right. So that's the general concepts of non-invasive cardiac output monitoring, such as the LiDCO is. Now this requires to have an arterial line in this particular scenario. Not necessary. We need to have an arterial line to get stroke volume variation. All right, is everyone clear on that? You need to be intubated. You need to have a closed chest. You need to have an A line. You need to have a regular heart rate because you don't want to pick up the variation from the heart. Okay. Now I'm in trauma. I am from Seattle, Washington, and there's a lot of young people up there that do a lot of dumb things. So a lot of my patients have really good hearts and they get really hurt really bad. So this technology is really great. If you're talking about a 95-year-old woman or man who has a really, really bad heart, you know, I say go for a PA catheter. Whoa, what? I don't think we use those anymore. No, yeah, I mean, so my point being is that this is a tool. All technology cannot fit all patients. But what I want to go to is the septic patient, because this is getting a lot of buzz with the new guidelines that are out. Okay, so this is a person who was in, let's say they got septic from, they presented with flu-like symptoms, they've been sick, not feeling very good. Finally, they got to the hospital, they're in the emergency department, they're profoundly hypoxemic, you guys decide to intubate them, and they start acting like they're septic. They hit the SIRS criteria, they come to your ICU, and you have sent off cultures, and this is your patient. So just looking at this, normal blood pressure is, we'll go textbook, 120 over 80. First question I'm going to ask you, are they compensating? Heart rate's 120. Are they maintaining their baseline blood pressure? So are they compensating? No, they are not. I hear a lot of people go, well, yeah, they are compensating, Deb, because they still have a blood pressure. But they're not. If they were, they would be maintaining their baseline. So problem number 1. This is cardiac output, so switch your brains up a little bit. Cardiac output's normal is 4 to 8. Is that okay? Yeah, as an absolute number, that's totally fine. What about this SVR? Are they dilated up or out, or they're way out? This happened to me just the other day on the unit. Got a call, they go, yeah, the part, I said, what's the, we were looking at output at the time, what's the output? And they go, 6. And I said, great, that sounds great. And I go, what's the SVR? 760. I went, oh, this should be like 12. There's nothing for the heart to be beating against, correct? Okay. Stroke volume is 50. Stroke volume variation is 25. What is this telling you? Let's ask the first question. Is your patient perfusing? No. Does your patient need fluid? Okay. Do you think your patient will respond to fluid? Okay, good. We all agree with that? Great. Okay, so let's give some fluid. But Leah runs over and says, Carrie, wait. I was just at NTI, and they're doing this passive legs raise thing all over the place. We're going to do PLR. Let's do it. Who does PLR at their facility? Do you do it? And you've done it, or you do it? Okay, because I'm a skier, and some people go, I've skied, and then some people go, no, I'm a skier. Okay, good. Okay, great. Okay, so this is all over the internet. You can Google it, but this is the best diagram because what you see is a patient in a semi-recumbent position with their legs up, or with their legs down, which is typical, head of bed over 30 degrees. What you do is you basically flip them down, keep the legs up to 45 degrees for 1 to 2 minutes tops, and you will immediately see a change in your stroke volume if they can respond to fluid. And we did this, and you can see in real time, over a minute, stroke volume went up. Why does that happen? What's the deal with the passive leg raise? Who was a brownie, a Girl Scout, a Cub Scout? What did they teach you in first aid? Someone's down, you gotta put your legs up. They knew this in the 1800s, people. What happens when you put your legs up? You get you give yourself a bolus. Now, I'm not much of a drinker, but those of you who may are really hungover in the morning, raise up your legs before you get out of bed. You give yourself a little auto transfusion, drink some water, you're good to go. Okay, so anyway, yeah, how much do you get? How much do we have in our legs? What do you think? What do you think? Okay, 300. Any other guesses? That's a great guess. I don't know. But we average about 300 to 500 cc's. So we'll say a unit of blood. That's a lot of auto transfusion. Wouldn't that be helpful for you to know? Now, anything else except one person to hold the legs up for 1 minute to know if they're responsive to fluid? You may not even need an order depending on where you work. We don't where we work. Okay, we just do it. And then we let the docs know, hey, by the way, we've got someone that's ready to respond to fluid. So we decide this patient's in trouble. We do a passive leg raise. We know they're responsive to fluid, so what are you going to do? They're sick. They're septic. You're going to give them fluid? How much fluid? You're going to go with 500? Okay, so perfect. That's totally fine. New sepsis guidelines say what? 30 cc's per kilo. Okay, that's a lot of fluid, people. Okay, and they say 70 kilo guy. That's 2.1 liters. That's a lot of fluid. I'll be honest. I'm at supposedly an Ooh La La trauma center. I don't know because I work there. You know, my head's down. And I would be hard pressed that we give a 70 kilo person 2 liters immediately. But we do. We give fluid. So we give this first fluid challenge. We're looking again for the stroke volume increase of 10%. So what do you guys think? Look at your numbers. Did the stroke volume go up 10%? Absolutely. If our stroke volume goes up, and even if our heart rate stays the same, you would expect your cardiac output or your index to go up. It's a math problem. Okay. Are they still way vasodilated out? This is a problem. This is a problem with sepsis because of the endothelial damage and the massive inflammatory mediators that cause this huge vasodilation. So I'm just going to ask you guys something. What do you do about that vasodilation? What do you do about that systemic vascular resistance that is just totally, everything's leaking out on the floor? What do you do about it? What? Levo, norepinephrine, pressors. Okay, so we're going to get there. What else can you do about it? Think of the septic patient. What's one of the very first things in protocol we do with septic? Yes, we immediately start antibiotics. You've got to get source control. Okay, good. Once again, we're in this part of the range. So we can confidently give fluid without, as you mentioned, doing an overload. So that's what we do. We give a second bolus. Stroke volume variation goes up yet another 10%. poor Miguel's a little hard. He's just all shriveled up on the ground. He needs to get pumped up with something. Okay, so here we go. Are you okay with the map? Now we know maps of 65 or greater are supposedly okay. Look at your systolic and diastolic, knowing that the person's normal blood pressure is 150 over 100. Are we okay? I don't think we're okay. Cardiac output, are you okay? If you look at it as an absolute number. Yeah, we're okay. We're okay. Then we look at SVR. How much does that heart have to work against? We're not okay. We're so not okay. Stroke volume, normal, low. Yeah? Are we okay? Kind of okay. So what are you going to do? And look at this. Is your patient going to respond to fluid after that second bolus? No. Heart's full now. To your point, we're worried about, are they perfusing? So what are we going to do? We're going to start with vasopressors, you guys. Blood pressure is tone. It's vascular tone, and we always think it's fluid. Every time we say pressure in the medical world, we think fluid, like intracranial pressure, fluid. Blood pressure, fluid. Pulmonary artery wedge pressure, fluid. But it's tone, and it's resistancy and flow. Okay, so here we go. We're going to start our vasopressor. What happened? I'm going to go back a slide. Look at these numbers. Okay, so your stroke volume is 65, 7.2 is your cardiac output. You have a systemic vascular resistance of 680, and look at your blood pressure and heart rate. They do not respond to fluid, so we wisely refer to vasopressors. How did our numbers change? Look at this. Stroke volume, did we go up? Yeah, we went up. That's really for me, and you please correct me or challenge me on this comment. Stroke volume to me is, if I have stroke volume, I take a sigh of relief. Because even without someone who has a heart rate to help us, and that's why neurogenic shock scares me so much, because we lose the compensatory response of the patient with sympathetic nervous system. Okay, so we start pressors, and they go on for a little while, and we continue to see our stroke volume going up. Our SVR, we're seeing a slight clamp down, which would be expected, but what really helps the clamp is source control, because we got to get rid of that bacteria or whatever the patient has. Okay, so look at the heart rate in the map now. What do y'all think? Heart rate's 100. Are we okay? I'm feeling better. Are you feeling better? I'm looking at your name there. I was going to call you out. Just covered up your name. Yeah, you feeling okay? Okay, so let's put this in context, you guys. We're looking at the entire picture. Here's an intubated patient who came in with flu-like symptoms, right? We're suspecting they're having some pulmonary involvement because they got very, very, very sick, very, very fast. They're profoundly hypoxemic. They're not making urine. They're now getting fluids and pressors. We have them on the septic protocol. This is where our patient's at. Their FiO2 has gone from 80% in the ED. Now we've actually been able to get it down to 50%. Where are we at with our patient? Can we rest for a second, or do we need to continue to press on? I'm going to let you decide. There's no right answer. We have a presser on her. I have a furrowed brow over there. She's looking to her right going, she's a loose cannon. She always presses on. Would you give more fluid with a stroke volume variation of 6, heart's flow, very shallow? Would you titrate up your pressors? What do you think, Laura? You're the one that thought pressors from the very get-go. After a little bit. Did you say after a little bit? Okay, give a little bit more and see how they do. Excellent. So this is my point, you guys. This is the point of this case scenario, is yeah, absolutely we can give a little bit more and just see if she changes at all, you know, or would it be okay just to pause and ponder? Tincture of time? We never do that. I don't. But you want to go for it? What do you want to do? You want to start him on another vasopressor? All right. Okay. You give more fluid. Okay, so now if you say give more fluid, I just want to make the point of this scenario, and you can. If you give more fluid to a patient's heart that is full of fluid, and you give more fluid, and they cannot accept that fluid to create forward flow, as known as stroke volume, what's going to happen to the fluid? It's going to what? Third space, yes, or they're going to go into their lungs. And then what happens when it goes to their lungs? What do we call that? Pulmonary edema. Has everybody seen that in their practice? Flash pulmonary edema? I have too, and it's profound, and it's awful, and you just think, oh my gosh, we've just taken an organ down. This person already had a sick lung. Okay, so what I want to ask you now, do you have any questions about what we just buzzed over? I just hit the salient points. And what's more important? Looking at these numbers or looking at your patient? Absolutely. This is a tool, you guys, and there's a lot of tools in the world right now, technologies in the world to help us with our patients. There's so many of them. But you guys are the ones that mean more than anything. You look at your patient, you see the global picture, you have that intuition, you have that weird sense of what's going on. And to Chris Schulman's point, you ask, why is my patient doing what they're doing? Or why are they not doing what they're doing? Okay? So when you go back to your facilities and you say, I was at NTI and I saw this really cool thing, whether it be this or other things, think about, one, does it fit your patient population? Okay, because all things don't fit all patient populations. And think about how it can help you improve your practice for better patient outcomes. That's all we're talking about. And we use this at my facility because it really helps us with the why in the road, fluid, or vaso pressures. Because we want, close your eyes for a minute because this always makes me dizzy. Because we want to know, I want to know, where is my patient? Are they here or are they here? Because if you give fluid and they can't accept fluid, what's going to happen to your cardiac output? It's going to dive, and then your patient no longer is perfusing. Right? Okay. Does anyone have any questions? That's the end of the what do you call that? So, the spiel.